في صوت صدى يا اخوان.
كذا واضح. في تشوفون السكرين؟
اي واضح دكتور، تفضلي.
واضح.
طيب شكرا. طيب بداية حابة أعرف عن نفسي. أنا أخصائية التغذية نهلة المشوح من قسم التغذية العلاجية، Head of Men Nutrition Section. حابين نتكلم اليوم عن السيرفيس تبع نيوتريشن especially for palliative patient. طيب بداية بتكلم عن nutrition pathway care process which consists from four corners, main corners actually for this pathway, from nursing, starting from nursing and then from food service. Actually nursing is usually they conduct nutrition screenings by using the nutritional screening tools and refer patients at a nutritional risk to the clinical dietitian assigned for each area and request the meal in the cortex. Then after that they refer to the clinical dietitian and they started to doing initial screening and reassessment, assessment and reassessment, evaluate the patient's need and the patient's response to the therapeutic diet or not, making adjustments as needed, recommended diet for interventions and appropriate actions or ordered sometimes by physician. Sometimes physicians, they prescribe the diet order and they asking the dietitians for or refer to the patients for dietitian for any editings or something specific needs for patient. So it should be from the doctors according to the medical status for patient. And then for food service. Food service, the one who is responsible, the last point actually for this pathway, who's responsible for food preparing and delivery of food service and identify patient's diet based on the order that is already submitted in the cortex. Okay, so this is the again the four main steps that they have the order goes through. Nutritional supported process. So again, upon admission, the patients have doing screening. If the patient's not at risk, after 7 days, they will making screenings for patients or refer to the dietitian. If the patient's at risk, refer to the dietitian, and according to the risk criteria, she will see the patients even patients, oncology patients or any other inpatients. طيب مثل ما تشوف بس هذا الفورم، حابة أشارككم هذا الفورم اللي معنا. زي ما قلنا هو within 24 hours to 72 hours إذا كان هو not at risk patient. هذه الكريتيريا الموجودة for الادلتس اللي بتحدد الريسك تبع البيشنت نفسه من ناحية هو under therapeutic diet، من ناحية الابيتايت، من ناحية difficulty of swallowing، عنده allergic or not. So they have to check for this factor. طيب بعد كده حيصير في assessment للدايتيشن للpatient's need within 24 hours to 72 hours. According to the risk, she will assess the patient and reassess the patient. زي ما انتم شايفين هنا الهاي ريسك within 24 hours، المودريت حيكون من 24 to 48 hours، low risk 48 to 72 hours. The reassessment maximum يعني within 7 for low risk patient with 7 to 10 days, or even for long term patients we can يعني take more days to review the patient diet plan. It's up to 14 days. Okay. I would like to show you some criteria for or categories for the factors. We decide the risk of patients, like appetite and intake, age, categories. If patients less than 75 years, so it's not يعني considered it's high risk or moderate. We will consider him low risk. But I would like to show you for oncology patients, all cancer patients with no GI complaints or symptoms. This will be low risk and moderate risk for all cancer patients on chemotherapy or radiation therapy with GI complaints, symptoms, and palliative patients. High risk head and neck cancer, GI cancer. So maybe this categories it must be shared with you. And also for regard the diagnosis, most of the disease we making categories for each disease. And I want to show you also the forms that we are using for initial and assessment and reassessment form. Usually this one we use only one time, so in the initial form, but this one for the follow-up patient. Regarding palliative patients and nutrition care plan, there's two there's a differentiations between levels of patients' compliance with the diet. So management for early palliative care is different for late palliative care. To do any assessment for patients, we should ask patients or ask some questions to lead us for better nutrition plan. Is the patient's normal food intake reduced? If so, why? Is it due to uncontrolled pain and anxiety or problems like dry mouth, sore mouth, taste change? Does the patient have difficulties eating? Does the patient suffer with the diarrhea or any other symptoms that reflect for food intake? So our interventions will be to some points. We're focusing in some points, like give patients small frequent meals, food preference, nutrition, and if patients need nutrition support or adding any additives. So according to their needs, we will deal with the patients, so on. And sometimes they now need to follow special diets rather than what they comfort. Because our goals in the early stage to improve metabolic and functional status, to improve the body compositions, to improve the quality of life during treatment of disease or during palliative care when disease is no longer responsive to curative treatment. But for management late palliative care, patients experiencing a general deterioration in the conditions, appetite reducing, in outcome, increasing fatigue. Other symptoms may also increase. So the goals of a nutritional therapy should not be weight gain or reversal of malnourished, but it should be about quality of life, including comfort, symptoms relief, and enjoyable food. Aggressive feeding may not be appropriate, especially if eating and drinking causes discomfort and anxiety for the patient. Our care, its aim should be encompass optimal management of nutrition-related symptoms, improved sense of well-being by the patients, optimize the patient's quality of life. So we can summarize this care plan for palliative care nutrition management in this graph. So early palliative care, we have to ask some questions if yes, like has there been a change in appetite or eating less than 15% from their requirements in the patient's anorexic or something like this. If it's patients having get a high score in this question, we have to refer to malnourished universal screening tools. It's referred to MUST. If not, so a team to determine most appropriate intervention. So dietitians with the primary team, they can decide the proper diet plan management for patients. In late palliative, it's most a little bit different. The aim is to improve the quality of life, including comfort, symptoms relief, as we said, and enjoyables of food. And also after that, ending with dietitians consult to give patients any further advice or any further needs. For patients' oral intake, it's recommended based on tolerance, also including some different kind of diet. Maybe sometimes it's high calorie, high protein, texture modification, sometimes for liquid, soft, puree, high fiber, low fiber. Other kind of diet, it could be iodine-free diet, the one who is under already a treatment. Neutropenic diet also we can recommend for some patients need according to their labs, which is low bacterial diet. This is the form that we can use inside our hospital to consult bring food from outside, approved by doctors for sure. We can find it in the internet also. For tube feeding patients, tube feeding it's not very recommended. It's not strongly recommended for patients under palliative, but sometimes the patients under consultations only, and they already long-term nutrition need the nutrition support. So there is some points we followed to delay enteral nutrition, like active GI problems or bleedings, operative bowel ischemia, high output intensity or fistula. Sometimes also he getting edema. Sometimes we need to just and give the patients the lower needs and give him the have maybe 15% from the requirement, And this is the list for formula that we are used usually for inpatients. According to the patient desire, we asking for flavors that he preferred, and we asking and according to his need or their needs, we will prescribe the supplement that it should be used. And we have inpatients formula inventory. We can use it different. We can use it for inpatients in different purpose. And also there is a discharge planning. Inpatients at nutritionist risk upon discharge will be referred to the nutritionist clinic before discharge. Of course, the clinical dietitian should be informed about 6 to 8 hours to prepare a proper diet for discharge. Because sometimes patients need for supplements at home, and we use this site to prescribe to him the supplement itself, and this one will take time, so it should be enough to endorse the dietitians before enough time. Okay, and also if patients need for clinic our clinic, to refer him to our nutritional clinic. We have, as you see here, in oncology clinic Monday afternoon. We have one clinic for oncology. You can refer patients immediately. هذه تقريبا يمكن كل الكلينكس الموجودة عندنا، بس for palliative patients, even main nutrition clinic or oncology, if the patients oncology patients. That's it for today.